All right, so welcome to episode 3, which is all about oncology. And here I have my wonderful, lovely colleague, Sally Woodhead. And so Sally has, oh my gosh, I forget the exact amount of years, many years of experience as an oncology nurse and as a midwife and as a clinical manager. Well, Sally,
Clinical trials coordinator. Yeah.
okay, I'll let you. Please, Sally, please tell us. Please introduce yourself and
Hi,
tell us
Jeremy.
your experience. Hello.
Thanks for having me on your show.
It's
I'm
ours.
Sally Woodhead, and I'm a clinical application specialist at EpiSoft, which is a cloud-based program, and I helped develop the front end of the Infusion Center software program at EpiSoft. Help with the workflow and the design of the pages and forms that nurses and doctors and pharmacists need to use,
There we
as well
go.
as scheduling and billing, letter writing, all that sort of thing, pharmacy ordering.
Oh yeah, very impressive. Sally is our very own Kath from Kath and Kim here at EpiSoft.
Well, I'm not sure if I should say thank you or not, Jeremy. I think I was
Oh my
being
gosh.
very coy there.
All right, there. That's the podcast right there. We can stop it, and that's all we need. Okay. All right. Well, look, Sally, I'll jump right into it. So, first off, right, when people picture cancer care, oftentimes they're picturing the treatment itself. But behind the scenes, in your experience, what does a normal day look like operationally for the average hospital, let's say?
It's often a big juggle to schedule all the patients who need treatment into the available chairs. Sometimes you'll have a full clinic, but you will need to fit somebody in who needs urgent treatment, and there'll be a lot of moving around of the calendar and the chairs to try and work out how you will treat them and make sure you have enough staff who are of a good match of skills, because you don't want to have all junior people on a day, and you need to have a mix of experience. You need to make sure that the pharmacist is aware that the drugs are required, and that they've been ordered. You need to make sure the doctor has produced a script for the medication. Of course, there's also pathology, so you need to liaise with the patient and make sure they have their pathology tests done before they come in,
Mm.
so that you have the results, so that the doctor can make a decision on whether the patient goes ahead with treatment, as well as, you know, getting ready all the equipment that you might need. So that's just for one patient, and some of our centres see 100 patients in one day.
Mm.
So they have, it's a major operation in the background.
Yeah, I mean, it sounds like a circus. It sounds quite complex.
It
No
is
pun
quite,
intended. Complex care.
yes, it
um,
certainly is.
no, and I mean, with all that, what do you, in your opinion and experience, what do you think is the kind of first domino that has to fall for a day to run well and relatively smoothly?
You mean a disruption that would create problem in the day?
No, no, like,
The first thing that you would need to do.
yeah, like the first thing that you think is like, okay, if we nail this from the start, then the day it'll help us have a more smooth day. Is there
Keeping the
anything
day
like that?
running on time. That
Okay.
is key. If
Yeah.
you have, and you will have delays, you need to expect delays. If a
Hmm.
patient has a reaction to a medication, you need to stop the infusion, maybe reintroduce it slowly. It may take hours longer to give that infusion, and the chair is booked for another patient.
Okay.
So things like that can throw your schedule out straight away. But then
Got it.
again, you might have another patient whose pathology results aren't quite good enough to have chemotherapy that day. So they might be delayed to a future date,
Hmm.
freeing up a chair. So there's lots of things can throw out the schedule, but
Hmm.
keeping it running on time while you have staff,
Yeah.
on at the required number of staff,
Hmm.
is key. That's the first most important thing to make sure.
Yeah. Time
Um,
management. and
Time
then
management.
being ready for the unexpected. It's sounding
Yeah,
like, yeah.
that's right. Yeah.
All right. Preparedness is next to godliness. No, I'm kidding. No,
No.
that sounds. No, I mean that makes a lot of sense. And like
Yeah.
we're kind of touching on it, but I mean, what do you also think that what makes oncology feel different from other areas of the hospital as a workplace?
It has a very different workflow and a very different atmosphere. So the patients are um, coming regularly in
Mm-hmm.
most cases.
Mm-hmm.
You try to give them the same nurse if you can, so that they have that continuity of care.
Yeah.
Um, the patients are coming in for treatment.
Mm-hmm.
They know they have to be there for that treatment and the tests, etc., but they don't
Yeah.
want to be there for any longer than they have to be. People with cancer, um, as you can imagine, life is precious and it
Yeah.
comes into focus as being even more precious.
Yeah.
And they don't want to waste time having treatment any longer than they need to be there. So
Yeah.
that's why making sure that the patient's treatment is timely and uh, their time is not wasted is really, really important. So,
Yeah.
because the patient is the center of the whole exercise. So, as opposed to a ward or a surgical ward, for example,
Mm-hmm.
you would have patients coming and going, you'd never see them again.
Yeah.
Or they might be inpatients for some weeks and or some days, and yes, time is important, but it's very different to when you're admitting somebody for 3 hours and
Mm-hmm.
then discharging them. That
Yeah.
sort of workflow is quite different. Also, the number of other services that are involved in a patient's care um, also are required to interact intimately with the infusion centre to ensure that you can proceed with care.
Yeah. Okay. And no, I mean, it sounds like, you know, the nature of oncology, like the relationships are so different because you're seeing them so often. Maybe it's difficult not to get more emotionally attached and vice versa. And it
Mm.
kind of sounds like maybe like the trust or building the trust within the patients is kind of a key to, what makes this area of care work.
Mm. Um, I think trying not to become emotionally attached is not necessarily a good thing.
Mm,
Of course, you don't want to be falling apart
yeah.
when you're trying to care for patients, and you do
Yeah.
need to keep in mind that you have more than one patient to look after at one time.
Yeah.
But if you don't become emotionally involved, you're not being true to the patient. You're not going to be able to gain their trust.
Yeah.
Well, of course, maintaining a level head, you need to connect with that patient and understand their fears and hopes and get to meet their families and friends who
Yeah.
come with them for the treatment, and you get to know them really well.
Yeah.
And if you want to really support somebody, you really do need to get to know them
Yeah.
well. And also, getting to know them means that if things aren't right, you pick up on it much more quickly because you know that person and you know that's not normal for that person. So
Yeah.
if they're having side effects to medications, they're more likely to tell you.
Yeah.
Oftentimes, they'll see the doctor, say, I'm feeling fine,
Mm,
and come into the clinic, and you look at them and you say, is everything okay? Have you been feeling all right? What about this? What about that?
yeah.
And it all comes out. And they didn't want to bother the doctor. They're so busy. They didn't want to tell the doctor because they might delay the treatment. They might
Yeah.
stop their treatment. And their treatment is what they're hanging on to get them better. And
Yeah.
they don't often always understand that continuing with treatment, if you have some side effects, can be very dangerous and
Mm,
counterproductive.
got
So
it.
it's really important to get that trust with your patient. Mm.
Yeah, that's beautiful. Yeah, just kind of making them feel comfortable to say the things that they might not otherwise say, but that are essential, right, for getting them that personalized care. That's
Yes,
really
yeah.
nice. That's really nice to hear, Sally. Um, and like, I mean, it sounds like obviously like nurses and coordinators, there's a lot that they have to. be thinking about, what are some of the other things that you feel, they do have to mentally hold together at any one moment, as they are doing oncology care?
Well, the nurse is heavily reliant on the admin staff as well
Mm,
to coordinate the calendar.
yeah.
They're also reliant on messages getting through from different services through the admin staff and passing on the important ones and
Hmm.
triaging the messages. The nurses and the pharmacists have a very close relationship because the drugs are compounded or diluted into a bag of fluid, the concentrated drug, and then that is then labelled and provided to the infusion centre. So some places do their own compounding,
Hmm.
but more places do external compounding, and so they need to put in an order in a way that it arrives in time. So in
Yeah.
time means in time for the patient, but also in time so that you will be able to infuse that drug before it expires. So
Yeah.
there are some
Wow.
drugs that have hours
Wow.
of viability after they're
Gosh.
compounded. Other drugs last a week. So
Yeah.
it's very important to liaise very closely with pharmacy
Yeah.
and
Gosh.
to make sure that the drugs are ordered, have arrived,
Yeah.
that the pharmacist is notified if the patient is cancelled so that
Yeah.
they can cancel the drug compounding because
Yeah.
these drugs cost a lot of money. Some of them are very expensive,
Yeah.
thousands of dollars for each dose.
Wow.
And if you have a drug delivered for a patient that is cancelled,
Mm.
then you need to store that drug until it expires so that if you can possibly reuse it on another patient, you will. Otherwise,
Wow.
it goes in the bin, thousands of dollars down the
Oh.
drain, and they will not be reimbursed. The hospital will not be reimbursed because um, they didn't use the drug on the patient it was ordered for. So
Wow.
it's a very fine tightrope to walk on.
Yeah, gosh. I'm playing a James Bond game right now, and it's great. But it like just these drugs, like within hours, it feels like that level of high stakes of the mission. It's like, quick, we have to infuse Woodhead. We only have 2 hours left.
Exactly, exactly. Is that right?
That's
That's so true.
I
Otherwise,
actually had
no, in the bin for you.
I had no idea about that. No, that's super intense. And I mean,
Mm,
yeah, it's like obviously like, that's a huge cognitive load thinking about drug delivery, access, consent, of observations. They're watching, and that's one patient like you've touched on, and a lot of them they're looking at multiple patients simultaneously, you know.
absolutely.
And I mean, with all of those things, in your opinion, what do you think is like the number one thing that can never leave front of mind, for these nurses, for these clinicians?
Um, is the patient getting their treatment and are they safe? So,
Yeah.
safety is the highest thing in my mind when I'm looking after a patient having chemotherapy or immunotherapy
Hmm.
or other drugs. Because a lot of these drugs are allergenic and
Yeah.
you need to keep a really close eye. So, if somebody says, "Oh, can you turn down the air conditioning? I'm feeling really hot," and you
Mm,
look at them and you think, they're a bit flushed in the face. They're probably having a reaction.
mm,
You know,
mm.
it's not hot.
Yeah.
They're not hormonal.
It's not a hot flash.
It
Yeah.
could be a hot flush. But that could be the first sign. Somebody says,
Yeah.
I've got chest pain. You don't
Yeah.
immediately assume they're having a heart attack. You immediately assume they're having a reaction to the medication. So
Yeah.
you need to be
Be
really
ready.
observant of the patients while they're having treatment and keeping your
Yeah.
eye on, you know, all
On the
their
ball.
observations and
Yeah.
um, yes, and how they're tolerating them.
Wow. No, that's, I mean,
That's
you know,
uppermost. Drug safety, patient safety,
yeah.
nothing's more important than that.
Yeah.
Mm.
No, that's very illuminating. I really like, even in these first few questions, the amount of respect I have for, all the people doing this work it was already high, but it's increasing. It's increasing with every question, Sally. um,
That's good, Jeremy.
yeah, but no, like I mean, these days already it sounds like every single day is difficult, from my perspective. But
Yes.
again, from what you've seen, what do you think an exceptionally difficult day can look like in oncology care? Like, what are some specific things you might see?
Well, I think probably days when you have a patient who's had bad news,
Mm,
their scan results aren't good.
mm-hmm.
They've had to change to a new treatment for that day.
Mm-hmm.
Getting their drug quickly organised,
Yeah.
ceasing the old one, and letting pharmacy know, of course.
Yeah.
Of course, looking after the patient, um, it's a very emotional time, and you need to support them through that, which takes a lot more time. We come back to the time factor again, and time is so important in the
Yeah.
running of a clinic, but you can't only think of the time it takes. You need to be there for that patient
Yeah.
to help them through that. You've also got other disruptions to your schedule, and
Yeah.
those, yeah, I think that's um, what was the question again?
Just, I mean, what are the things that make it a really difficult day? I mean, I know you like
What
getting bad
makes a really
news.
difficult day? I would say that
Yeah,
would be
the
that
worst.
and delays in the clinic running.
Yeah, yeah. No, I
And
mean,
reactions. Having a patient with a
mm,
reaction is
okay.
obviously
Yeah,
requires more than one staff member.
yeah.
Everything
Mm,
stops. You've got to focus on that until the patient's stable again. And yeah, those
okay.
things take time, and you need to
Yeah,
support the patient through that too. So
yeah,
yes, those two things: bad news and a change of treatment,
yeah,
and a reaction to an
yeah.
infusion.
Like nasty
Those things
surprise.
really throw your day out. Yeah.
Yeah, and I know too. You've kind of talked with me about like how unfortunately common it can be with like short staffing or people who on the day can't get there, things like that. I mean,
Yeah.
do you feel that is still quite common?
Yes.
Yeah,
Totally. And I
yeah,
think hospitals, are run as businesses and need to make sure that they are on the budget.
hmm,
And often they think that, I think that it's probably assumed that nurses will just expand their abilities that day and just cope with more patients, more complications,
yeah,
more things to do. But
yeah,
most of the nurses in oncology units that I've seen, and I've been all around Australia and
hmm,
overseas, are pretty close to their limit
yeah,
for safety. Some are past their limit for safety. So in some centres, you see that there are more patients than staff can comfortably cope with.
yeah,
That the staff aren't a good mix of experience and inexperience,
hmm,
and that there is a high level of stress.
yeah,
Now, this is when mistakes occur, when
yeah,
um, things fall apart, and
yeah,
they do sometimes. And
yeah,
so preventing errors is really important, obviously.
yeah,
And that really does come down to staffing, good
yep,
staff, experienced staff, a good mix of experience in your staff so
yeah,
that you're always training new people, but you have the experienced staff to mentor them and to
hmm,
support them when things are out of the ordinary.
yeah,
Yes,
yeah. That's full on.
it
And
is.
I mean, it's still I'm still so shocked at that whole idea of like you can't simply reschedule a delayed patient because that drug's going to expire. And like I'm understanding how quickly things can escalate how quickly things can escalate at an infusion
Yes,
center. And
yes.
like I can only
Also,
imagine.
you've got some
Oh,
treatments for, say, adjuvant breast cancer, where
hmm,
you're giving them chemotherapy to mop up any cells you might have missed in surgery,
mm,
um, and you're hoping for a cure.
yeah, yeah,
Apparently, if you don't keep that regimen on schedule every 3 weeks, for example,
Hmm.
if you get more than 3 days out with your treatment, it can be the difference between the protocol, the whole treatment working or not working. And
Wow.
if it's
Yeah.
not, or not even being worth giving, really, because
Wow.
if you
Yeah.
don't, you need to keep it at that schedule because that's what the clinical trials have said
Yeah. It's
is,
very
and has
delicate.
been tested as working, and there's no evidence to support any other schedule outside a
Wow.
3 day window. So it can be very important to make sure your patients are treated on time. Mm.
Gosh.
In that
Yeah. Wow.
circumstance.
You're really putting the complex and complex care for me.
Mm.
That's wild.
It's
Okay.
very, very complex, and there's so many
Yeah.
nuances with each type of cancer and each type of treatment that
Yeah.
you need to be mindful of.
Yeah, like I saw a video yesterday, I think, and it was like a bunch of oncologists at a conference, and like they were all clapping for a drug that is like more effective than past drugs have been, specifically for pancreatic cancer. And they're all like giving it a
Mm.
standing ovation. And I was like, wow, like,
That
you
is,
know,
yeah, we
yeah,
really need better drugs for pancreatic cancer. It's
good.
quite an aggressive cancer.
Yeah.
Um,
Yeah. You know what? No, my grandmother, I was trying to think, I don't think it was pancreatic. I think for her, it started as ovarian cancer and then
oh,
it just spread all the way through everything. But
yes.
then she was like, at that time, she was ready to go because her husband had just passed away a few years prior from Alzheimer's, and like
Mm.
she was the kind of person, she didn't even want to go to the hospital, even
Mm.
though everyone urged her like to go get checked. And she kind of waited until like, sh I think she kind of knew it was too late. And then she
Really,
finally went and they confirmed, oh yeah, you have stage 4, this.
you
But
need to be in a very fit state with a very strong constitution at the time to be
yeah,
able to cope with the chemotherapy required for ovarian cancer and
yeah,
many other cancers.
yeah,
Although the pre-medications now prevent a lot of the complications like the nausea and vomiting, they've reduced that dramatically
yeah,
in the last 20 years.
yeah.
It's still quite rigorous chemotherapy to go through, and
Hmm.
it needs to be taken into context with that patient's whole life.
Yeah,
And if they're elderly, they've lost their partner,
yeah,
they want quality, not quantity of
yeah.
time, then you must respect that. That is a patient's decision.
Yeah, yeah, yeah. That's it's a beautiful aspect of it as well. And
Mm.
and we've kind of touched on I think different parts of treatment and prescribing, but I think it might be good to like kind of see the whole picture. Could you walk us through, Sally? What has to happen between the doctor deciding on treatment and that drug actually being administered to the patient? Like, what's I guess the step by step typically?
Okay, so depending on whether the unit uses paper,
Let's go with
um,
paper. Let's see what does it look like first on paper.
okay, on
Hmm.
paper, a doctor will see the patient, decide they need treatment,
Hmm.
make a phone call, and to the clinic and ask that the patient be scheduled for the treatment. Then
Hmm.
they will phone the doctor, or the clinic will phone the pharmacy to let the pharmacy know that the patient needs this treatment. Then they will write out an infusion order, handwritten or printed out,
Hmm.
um, and the pharmacist will usually come down to the doctor's rooms,
Yeah.
and or the doctor will fax it to the pharmacy. So getting that paper to the pharmacy, it varies. That's why faxes are still used in healthcare.
Wow.
Um,
Yeah.
uh, and then the pharmacist will look at the medication. The clinic will look at the order and when the doctor wants the patient to be treated, and they will talk to the doctor's receptionist and arrange the preferred time. Then the admin staff will call the patient and ask them if that date and time suits the patient and adjust it as necessary. And then then the admin staff will call the pharmacy and let the pharmacy know when the patient wants to be treated and that they've been scheduled into the calendar for that time. And then the pharmacy will um, put in an order for that drug the day before, or if it's in the country, maybe several days before, they will put an order in with a dose calculated on the most recent patient's weight.
Yeah.
And then the drug will start to be compounded the day before or the night or the morning of the treatment.
Mm.
And then the drug will be delivered to the pharmacy. The
Yep.
pharmacy will then check the labeling, check with their records, and then they will deliver the drug to the infusion centre. The patient will arrive, the
Mm.
patient will be admitted and taken into a chair. They'll be have their arm heated up with a hot pack, or they might have they might have a portacath or a PICC line, which
Mm.
are permanently attached lines into the patient's bloodstream to infuse the treatment.
Wow.
But a lot of patients have a cannula put in, and
Mm.
um, then the pre-meds will be given. This is also after educating the patient, talking to the patient. So you may have scheduled an education session
Yeah.
on a day prior to the treatment starting. So the patient will
Wow.
come in for 1 or 2 hours to have education on that drug and all the
Yeah.
side effects to expect, and what they need to do. So, yeah, so then you give the pre medications and then you'll flush those through with some sodium chloride or glucose, and then you'll start the first drug and ensure that you keep a close eye on the patient, doing observations on them regularly to make sure they're okay. Um, it just, yes, so
Yeah.
that's sort of the process.
Uh,
In that process, I didn't mention that the patient has also gone to pathology to have blood tests taken, unless they have a portacath, in which case you'll take the blood from the portacath and you'll send it to the lab yourself to save the patient having a needle stick in their arm as well as a portacath access. So, yes, so that's the sort of process. Um, yeah, I'm trying to think of what
it's
I've missed there. And then, of course, when you're
there's
finished, you
more.
flush the drug and then you put the next drug up, and this goes on
Yeah.
until you're finished. And then you have to check the drug with another nurse to make sure
Mhm.
it's the correct patient, correct drug, correct dose, um, and um, and that the order is for the right day and the right time, and that you know the duration that that drug needs to be infused over, and you might need to then set the pump if it's a manual pump that infuses the medication at a certain drip rate, or it might be a smart pump which is integrated with the system. So there are lots of little checks in there. And then the patient, when they're finished, you'll flush the drug through, you will give them information on their discharge medication, what they need to take home, and when they need to take those drugs, and then
Yeah.
you will discharge the patient and they will go home. And then usually the next day you'll phone them to see how they are, see if they're
Yeah.
coping all right, if they're having any problems. So that's what one patient's first treatment would be like.
Yeah.
And then, of course, the pharmacist will have to go down to the doctor with
Yeah.
the script written out usually and get the doctor to sign it. That's the process that used to happen when I was working in an infusion centre where paper was used
Wow.
quite a few
Yeah.
years ago.
That's
Hmm.
quite a pipeline. That could like well everything you just said, that could honestly be turned into like a monologue in a play, and then the character is just like getting more frantic by the end, and then they stop, and then the audience will just be like everyone will just be right there, like, wow, that's nuts.
Oh dear, yes,
Oh my
that's right.
gosh.
Yeah.
No, but I mean, no, that's very informative. And I mean, it sounds like because of all those things, is it the case that frontline staff often have to end up as the glue when there are more disconnected systems or disconnected teams?
Oh, absolutely. There's a lot of sticky notes and
Sticky
um,
notes.
and phone messages, and yes, a lot of um, to and froing. There's a lot of time taken
Yeah.
with communication. Communication is the most difficult part in a disconnected system where everything's on paper,
Yeah.
and making if you need so if the doctor makes a change to the dose of a drug, that
Hmm.
needs to be done on the paper and then signed by the doctor and then brought to the infusion center, and so that the nurses can then administer that different dose. The pharmacists will need to make sure the compounder makes a reduced dose if the dose has been reduced, for example. The nurses need to change the timing of the infusion, so it's a
Mm.
different drip rate, and this quite a few adjustments might be needed.
Yeah.
Mm.
And so obviously, you mentioned the sticky notes and how much people have to remember things, trying to chase things up, and kind of keep all this information in their heads.
Yes, yeah.
How much of oncology workflows do you feel still rely on people having to do that?
I think that totally depends on the system they're using. So,
Yeah.
obviously, on paper, a lot.
Yeah.
For those organisations that use the hospital-wide EMR,
Hmm.
electronic medical record system,
Hmm.
and doesn't that don't have a cancer-specific program, I think probably still a lot, because there's a lot of the workflow that is not covered on most hospital-wide electronic medical records.
Hmm.
Um, the rescheduling is so complex with chemotherapy and immunotherapy that it's uh, mostly not coped well with by an EMR,
Yeah.
um, unless it's cancer specific. So if you move treatment, you might want to move the treatment for today to tomorrow and not
Yep.
change anything in the future. Or you
Yeah.
might want to change this whole cycle by one day. So if there's a public holiday and the patient's booked in to start treatment on day one and they have a day 8 and day 15, day one is moved to Tuesday instead of Monday. You'll probably want to move all the day one, the day 8, the day 15 to the Tuesday, for
Hmm.
example. But you don't want to change following cycles because the patient likes Mondays.
Right.
So you will change just this cycle. You might want
Hmm.
to, if you've delayed the patient by a week because their neutrophils are low, you will want to delay all future cycles by 1 week.
Yeah.
So
Wow.
to be able to do that in an EMR is very difficult. They
Yeah.
mostly don't do it. It's mostly a fairly manual process,
Yeah.
and of course changing all the um, notifications to pharmacy that those dates have changed, and
Hmm.
yeah, so many things have to
Yeah.
change, um, that becomes quite complex if you have a system like that. So it's
Yeah.
a lot of manual moving in the calendar,
Yeah.
phoning. Um, yes, it's
Yeah.
very time consuming.
Yeah. And I
Mm.
mean, when scheduling breaks down, let's say there are unexpected things and, a service is not ready for it. And let's say they have to, like, does it often happen that they have to delay patients or push their appointments or even like forcibly reschedule the patients? Is that something common?
It happens now and then. I think
Okay.
everyone works really hard to stop that happening, but it
Yeah.
can happen
Mm.
that um, the communication lines break down and the patient arrives for their treatment and
Hmm.
the drug has not been ordered. So you can't just ring up and say, oh, quick, we need this,
Yeah.
unless you have an in house compounding ability. You
Yeah.
can't get a drug delivered in time. And
Yeah.
also, make the patient wait a few hours while you get that drug delivered. Generally, you'll have to reschedule. So, those circumstances don't happen too often, but they do happen.
Yeah.
You're also getting blood products from the blood bank,
Hmm.
and you need to make sure the order has gone into Bloodstar and that Bloodstar have approved the
Yeah.
order and what date the expiry is. So, you need to know whether you still got the right to give the patient that blood product, because if the expiry has happened on their approval and the patient's booked in for the following day,
Yeah.
and you've ordered the blood product, it won't turn up because the approval's expired. You need to apply for another approval. The doctor
Yeah.
needs to do that, so the doctor needs to know when the it's very complicated.
Yeah. I know. And
Those are
I,
the circumstances I can think of off the top of my head where patients had to be delayed to another day because
yeah.
the approval wasn't there, the product wasn't delivered, and
Yeah.
yeah, the patient arrived. So mm,
I can imagine, beyond the clinical
imagine
cost,
doing
I'm
all that
sure.
on paper and keeping track of it. It's
Yeah.
really, really hard.
No, and I can imagine it'd be difficult too, when you're trying to build those good relationships and trust with the patients and beyond the clinical costs, just, I guess just
And
seeing what that might do to them, when it
yes,
comes
and
to,
some patients are very understanding, and other patients are na- n- n- op- understandably upset.
yeah, yeah, I
And if
know.
it's
Everything to
chemotherapy,
do.
well,
Yeah,
it's not a good thing to have it delayed in a lot of cases.
yeah, it's very sensitive.
Yeah.
Okay. Yeah, no, that makes sense. I mean, what does when it comes to consent documentation, what does that usually look like in practice? And if it isn't where it needs to be at the moment treatment starts, uh, you know, what might that look like?
So consent to treatment, consent um, to the cost of treatment are both separate, different types of consent.
Hmm.
But in most units, it's a legal requirement that you have a written consent from the patient for that
Hmm.
particular treatment.
Yeah.
So you would get the patient to sign the consent in front of the doctor after the doctor had explained the treatment and the patient said that understood.
Hmm.
They would sign that. It would be scanned into the system if you use a system and then stored in the patient's documents.
Yeah.
So on paper, it would be in a paper record. So you would need to find that document before you start the treatment and make sure that it hasn't expired. So some expire at the end of the treatment protocol,
Hmm.
so the series of cycles. Others expire annually. So it depends on your system at your hospital. Um, with EpiSoft, we have the ability to attach the consent to the protocol, so the nurse can see that on from the drug admin screen. There's a link to the consent, so they can see if
Yeah.
it's still current. And it actually has a traffic light system, so that the button to the consent page changes color if the consent is expiring or has expired, and it's green if it's current,
Yeah.
which makes it very, very quick and easy to check whether the
Yeah.
patient has consent. It also shows on the appointments so that when the admin staff book them in, it will have an icon on the appointment to tell the admin staff if the consent is expiring soon,
Mm.
so that they can notify the nurses before the patient comes in for treatment, notify the doctor that this is required, and then the doctor can organise with the patient to sign a new consent.
Yeah.
So consent can be a hold up and waste time. And of
Yeah.
course, time is precious for the patient, time is money for the hospital. So
Yeah.
all this wasting time is huge expense.
Yeah.
But
Okay.
people think, getting um, a tailored oncology medical record system that integrates with their hospital system, they think, oh, why would we want that extra expense? Why can't they just use the hospital EMR?
Yeah.
I think maybe you can see from what I've been saying that there is so much complexity
Yeah.
in managing a cancer patient having treatment in an infusion centre that the general EMRs just don't have that detailed functionality.
Yeah.
So, for example, with EpiSoft, when you change that treatment time,
Mhm.
date, for example, and you can choose the just this day, just this cycle, all future cycles. It's same with medications. If you want to reduce the dose, just a day, just this cycle, all future cycles. We've got options like that, and it all happens seamlessly and moves all of the dates or all of the drug changes through, cycles them right through all of the protocol cycles that have been booked, and gives you a history of the changes. So you can see the appointment changes and who changed it, and at what point, and what they changed it from and to. And with the
Yeah.
medications, you can see what it was and what it was changed to, by whom, when, um, and on which cycle. So you've
Yeah.
got a huge amount of information built in, that and an ability to change things, to reschedule, which I think
Yeah.
is the biggest time waster if you don't have an electronic medication record that does this kind of rescheduling.
Yeah. I
Mm.
mean, I definitely can understand, when people try to do all of these complex workflows within generic hospital systems, I hear, the time, that definitely can be wasted, as well as, the unnecessary stress that can be created.
Mm.
How often do you think that, in those, I guess, circumstances, it moves beyond inconvenience to actual safety risks for the patients?
I can't imagine how it wouldn't.
Yeah.
Safety
So
risks.
so 100%, a
Yeah.
100% of the time.
Whenever you have delays or time consuming tasks,
Yeah.
it delays things. When
Yeah.
people are stuck doing something like rescheduling,
Mhm.
they're not focusing on other issues that are coming up for them.
Yeah. Their
Um,
eyes off the ball, the proverbial ball.
yes, yes,
Yeah.
they're stuck in the weeds when they need
Yeah.
to be swimming down the stream. If you want to have a
Yeah.
nice little analogy under the water there.
There we go. A healthy oncology nursing salmon just just making its way down. That's the new EpiSoft logo, just a huge pink salmon. Just
Yes,
EpiSoft.
have some nice blue stream.
Yeah. Flow with the oncology stream, no.
Flow, yes. So
um
flow,
and
yes,
yeah.
being able to see that flow is so
Oh my
important.
gosh. And Sally, you know what? I think you were just explaining a lot of this in terms of access to information and, workflow simplification. Are there any other kind of changes for staff and for patients that you haven't touched on yet that you think really emerge once they do have workflows and systems that are predictable, that are consistent?
Well, I think it is an extraordinary thing to see a centre go from paper where they are very busy,
Yeah.
but they know how to do it. They understand the workflow. They know what they have to do.
Hmm.
It's huge, and they're used to all the juggling with paper, etc. And then you go through that change management process where they don't want to change, they have to change, they start learning, they say it's going to be overwhelming, then you show them it's not, and then
Yeah.
their lights come on and they think, okay, this looks really good. And then they start using it, and it's you go back there a few weeks after they've gone live and people will just say, it's saving me so much time, I'm not missing anything anymore, I can
Mm,
find out information so easily, I can go back in the past as far as I need to, I can
mhm.
search, it's just amazing. In fact, I remember one pharmacist at a big hospital in Australia said to me, on average, she's saving 4 hours a day.
That's huge.
I
That's
said,
more
how
than
did
Lord of the
you work that out?
Rings.
And she said, well, it used to take me this long to do the drug ordering
Yeah.
and to check all the patients and do all the clinical checks before I could sign off on
Mm.
that order. And then I'd have to do that for maybe 80 or 100 patients for every day.
Oof. Yeah, yeah, yeah.
It is so much faster. All the information is on the pharmacy page. I can
Yeah.
find out everything that I need to know to say, yes, this is good, this is right, we can go ahead with ordering the
Yeah.
drug. So she said, yep, I'd say 4 hours a day.
That's
Ah, I
gnarly.
couldn't believe it. And you think, well, that's got to be a cost saving for the hospital. It's got to be a saving in reduction
Yeah.
in errors, um, reduction in staff time wastage so that
Hmm.
staff can be focusing on what they need to do.
Hmm.
Not necessarily with fewer staff, because I think people were
Mm.
stretched to the limit in a lot of places. But
Yeah.
um, yeah, allows the staff to do their job and
Yeah.
care for the patients who are the centre of the infusion centre's universe.
Yeah. No, that's beautiful.
Everything works around the patient and their wishes.
I mean, and when we have oncology services that, they genuinely feel calm and under control, is there anything else you feel like they all have in common?
For centres that feel calm and in control.
Yeah, like when you see an oncology service, or let's say if you grouped all of the oncology services in Australia that you think are running smoothly, efficiently, wonderfully. We've talked a lot about the EMR, right? Like what impact obviously a complex care EMR, specifically oncology EMR, can do. Are there any other common traits that you think these kinds of services have in common?
Great leaders. So
Great leaders.
having people who are uh, confident to make change,
Yeah.
confident to see problems and find a solution,
Yeah.
uh, leaders who make their staff can, who treat their staff as the um, gold that they are. That
Oh, yeah.
the precious resource that they are, the irreplaceable people that make an infusion centre for people with cancer safe and
Yeah.
welcoming and tailored to each person and caring. Uh, that who's a leader who supports that kind of atmosphere, you
Yeah.
find that people want to be there. People will go the extra mile to make
Yeah.
the patient um, happy and well cared
Yeah.
for, and to work with other people in the system, all the other
Yeah.
services. They're happy
Yeah.
to do that if in a well run unit.
I
So
love it.
the nurse unit manager, the um,
The num num.
yeah, the IT people who choose, might be in charge of choosing the system, the doctors,
Yeah.
all of those people, if they value their staff, it's
Yeah.
it makes such a big difference. Yeah,
I love that. Where purpose-built ecosystems meet purpose-built software.
absolutely. You said it, Jeremy.
Wow. Oh no,
I've
I think
really
that's
enjoyed being at EpiSoft for 13 years now, and
yeah.
being,
Well, clearly.
having a say in
Yeah.
how it's been developed, having a
Yeah.
say in whether the forms work for the
Yeah.
people that are using them. So the nurses get forms that fit with their workflow and what they want to see.
Yeah.
And I get little tips coming in, sometimes on, social media, or
Yeah.
sometimes by email or phone call. Sally, we really want to be able to have a quick link from the appointments to do a set of OBS on a patient. If we're doing regular OBS on 6
Yeah.
patients, to have to open up each one's record and find the OBS page and then
Yeah.
record the OBS. If we could just have that link. So
Yeah.
got that. I pushed that one hard, got that
I
one
love
through.
it.
We've now got a little heart that you click on next to the patient's name on the appointment,
Cute.
and it
Yeah.
opens up their observations page, and you record them
Perfect.
and it saves it back to that patient, and you can then do
Yeah.
the next patient. So
There
things
you
like
go.
that, being able to have
Yeah.
a difference to the workflow of the nurses, and like
Yeah.
the admin staff. If the doctor ceases a drug on the protocol that might take an hour,
Yeah.
the admin staff will see on the booking request page that a little note saying a drug has been ceased on this protocol. The duration
Hmm.
may need to change of the appointment,
Hmm.
so that they know they can shorten the appointment, which allows them to schedule that chair for other patients who need it. So,
Yeah.
you know, I just
Yeah.
love being able to affect little things that make the
Yeah.
day better.
Well, there you go. Well, it's like they say, the customer is always right, which
Mhm.
has been widely misinterpreted. It doesn't mean that like literally everything they say is right. It's just like the customer knows what they need or what they want, or like
You've got to
they'll
listen.
get the thing. Yeah, and so it's like, give the people what they want.
Yeah. If you can possibly do
To an
it,
extent.
you've got to try to listen to
Yeah.
your customers, and
Yeah.
do the things that are close to their hearts and going to make a difference in their day. Mm.
Yeah, right. As long as the things they want are beneficial to humanity, unlike
Yes.
a lot of the tech companies and other we won't get into all that anyway.
No.
um no, that's beautiful. And what also doing this role, I have come to appreciate, like, like you said, there's so many different services and different kind of levels of the hospital, and everyone has a lot on their plate. Things are trying to get done right. But I've also seen that sometimes there can kind of be like a disconnect where certain services or certain roles don't realize really what day to day looks like for other parts of the hospital. What do you think it is that hospital leaders often underestimate about the operational reality of running an oncology service?
Um, I think the main thing that hospital operators underestimate is the time it takes to really give good care.
Mm,
As I said, time.
yeah,
It comes down to time again. Um,
yeah,
um, Thinking their staff can do more
hmm,
with less, um, and still do it really well. That just
it's not
doesn't make
realistic.
sense. It doesn't work. That's when
Yeah,
you introduce risk. Risk is a cost to the patient, but it's also a cost to the hospital because when things go wrong, nobody wins. So making
yeah,
sure there's adequate staffing, making sure that staffing is a balance of experience, making sure
mhm,
those staffs aren't overloaded with
yeah,
patients who may have complexity beyond their current ability. And
hmm,
yeah, I think I would say value your staff and
yeah,
try and think in their shoes a little bit.
yeah, yeah.
Thinking
No, that's
nurses
sweet.
in this way, but also pharmacists
Yeah,
and admin staff that are all under pressure.
yeah,
Every infusion centre I have been to, everyone is busy. They're all under
mm,
pressure, and
hmm,
busy is fine, but stressed and overloaded is dangerous. So yeah.
yeah. You want to make sure they're equipped.
Hmm.
Try to avoid those one-star Google reviews from poor from poor service. you know,
Exactly,
you
exactly.
know how like luxury like clothing companies and bag companies and stuff, they'll send like secret shoppers, right?
Mm.
To like make sure there's I wish there was a way that it's like, oh, it's a secret patient, it's actually somebody like from corporate or whatever. Just make, it's like, what's the level of care that's happening right now? They're
Yeah,
getting medication they don't really need. Oh no,
give
no,
me a
no.
little bit of chemotherapy, and I'll let you know how you go in the
Yeah,
bit.
yeah. It's like, oh my gosh, they're just passing out.
Ah, maybe not
Oh
chemo.
my gosh. There's gotta be a safe way. No, I'm kidding.
A vitamin
Um,
infusion, perhaps.
yeah, there you go. There you go. It's like swapped in, it's like the newest Australian reality show. Secret patient. But
Braver person you'll never find.
oh, there you go.
Mm.
That's EpiSoft will branch out. I'll produce the show. No. Um,
Sounds really
you know.
fun, Jeremy.
Yeah.
I think that'd be really cool. You're going to be
Oh
the
yeah.
first guinea pig,
I
yeah.
know. After the years, it's like, here's all the unnecessary drugs that Jeremy has had infused and taken into his. We don't know how he's alive. No. um, no, but when there are services, that I guess don't have that support,
Mm.
don't have that investment in them, what do you think is like the number one thing that can wear people down over time?
Um, Not being able to provide the care they want to the patients,
Mm,
having to rush people, having to not have time to listen to the patient because that's often the first thing to go. You don't have time to sit down and actually talk to the patient, which is when
yeah,
you find out really important information. Um,
yeah,
that takes away your job satisfaction as well.
hmm,
So, job satisfaction for all staff, nurses, doctors, pharmacists,
hmm,
relies on being able to have a relationship with people. And if you are rushed off your feet, um, yeah, not being able to have that time with people is probably one of the most affecting things
yeah,
for your satisfaction,
yeah,
and the worry that you're going to make a mistake because you aren't spending the time you need to on
yeah,
talking, checking drugs, checking patients. You know,
hmm,
you can't be everywhere at the same time, and you need to have eyes on all patients at all times.
yeah.
Mm.
That really increases my empathy because like of course I've been in situations where I feel like the doctor or the dentist or whoever I'm seeing like doesn't really care about me, and it's kind of like I'm just like another body, like another number. And
Mm.
what we're talking about helps me realize it's not personal. Obviously it's something you want to try to avoid, but now it's making me think about, well, what are all of the cogs, you know,
What's
in the
caused them to be
machination?
like that?
Yeah,
Is it
that's
self-preservation? Is it how do
yeah,
I get through my day if I talk to people? I won't
yeah,
get through my day. So,
yeah,
yeah, that's what goes, that personal connection, that time
yeah,
with people. That's what
yeah.
goes. That
Which
personal,
does,
yeah.
yeah, which does, like, as a patient, it does make all the difference. You know what I
I
mean? And like,
know.
you just feel like, oh wow, like this person
Totally.
really cares. It's like,
Yes.
oh, am I pre-diabetic? Thank you for sounding like you care about that.
Yes. Yes. That's right.
Oh my gosh. Yeah, but okay.
Exactly.
Okay, and so the last question, Sally, and already, we've kind of already talked about some of these things too, kind of
Mm.
gotten around it. So if nothing springs to mind, don't feel pressured. Maybe you've already gotten it all, out. But if a hospital executive, was listening to this right now, what is, one thing you'd want them to genuinely understand about what it takes to run oncology well? If there is, because I think what you said about just investing and caring about people, treating them like gold. I mean, maybe that's already it. Is there anything else you'd want to add to that, or?
I would say keep your eye on the bigger picture.
Mm,
I'd say most people in managing a hospital would be doing that. But
yeah.
it's not just that, it's the long term gains in time saving for putting in systems that are tailored to the organisation, to the type of patient they're treating, as in
Hmm.
cancer.
Hmm.
The upfront cost, ongoing cost, weigh that up against the time that the nurses can then spend with the patient, the time that pharmacists will have to check and recheck that the drugs are all accurately prescribed and dispensed. That time saving is worth a lot of money,
Yeah.
because you will avoid a lot of errors and a lot of stress and staff turnover by investing in systems that assist your staff to run that infusion centre smoothly, to be able to care for their patients effectively, and to get real job satisfaction. And I think you'll find that the cost uh, is paid back in spades with those savings of time and reduced errors and increased satisfaction and reduced staff turnover. Mm.
So as a salesman, I'll translate. You got to spend money to make money. No, I'm just kidding.
Yeah, 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 pretty much.
No, that's I think you said it like so beautifully and
It's
empathetically
a
and
juggling
eloquently,
act, I
Sally.
understand, but
Yeah.
it's something that a lot of health organisations need to think about really carefully.
Yeah.
Make sure your system is tailored for the disease you are operating for.
Yeah.
That it can manage all of the complications and changes that are required in the schedule. That
Hmm.
that it will do what you want it to do,
Yeah.
and do it in a really intuitive, simple way
Yeah.
that's
No,
easy to learn.
yeah.
Then you will find you
Tell
don't,
people.
yeah, you
And
reduce
Sally
your
will train you.
problems and increase your revenue.
Yeah, there you go. No,
Yeah.
Sally, like it reminds me of there was this short story I read some time ago and it stays with me. And it's a bit dark in the name. It's called Bullet in the Brain.
That's
And
a
it's
bit.
about this it's a it's about like this a literary critic or a movie critic, just a critic, right? And he's at the bank, right? And there's a holdup. And then basically he gets shot and dies. But the moment that just before he dies is elongated, and like the author shows us how now he's like a hardened, cynical, pessimistic, old man. But we see that when he began, he started with such purity and such
Mm,
love, and like he had all the right intentions, all the right reasons.
mm,
And over time he just became something that he would have hate like the pressures of the job turned him into something that he would have hated when he
Mm.
started. And I feel like no matter what field you're in, what specialty you're in, I feel like,
Politics. Mm.
right?
You see a lot of
It's like a
politicians going down, starting out
yeah,
pure with great
right?
intentions.
Yeah, it's like a very human danger, and which is like I love that short
Yeah.
story, and I feel like that's part of like this
Yeah.
message is like, can you remember, you know, why do you care about patients and healthcare, and what really matters at the end of the day, and then can you still kind of carry that through as you balance all the realities of fiscal pressure and end of financial year, and you know what I mean, and AI is coming for all of us, the headless
Mm.
horseman of AI, and
Oh, golly,
but
isn't it? Yeah.
yeah, but I think that yeah, I think that was very beautifully said, Sally. And so
Thank you.
thank you, anybody who's listened here to the end of this episode, we thank you wherever you are, if you're on YouTube or in the car commuting, or you should be checking a patient right now, but you're playing us on Spotify. Thanks for thanks for listening. But we hope that it's been useful, beneficial, informative, entertaining, anything positive. And thank you, Sally.
Thank you, Jeremy.
Yeah, for
Thanks
taking
for
the
inviting
time.
me on.
Of course, no, I think I loved so many of the things that you said. And look at that. See, I think it went amazing. I hope you feel the same way. You're a natural.
Well, I
You
hope
got.
that it's hope that's been beneficial to people that are listening, and
Oh
yeah,
yes.
it's a bit of a privilege to be able to say all these things that I
Yeah.
have hold dear to my heart. Yeah.
There we go. You got something, kid. You got something.
Oh, thanks. Sure.
All right, my pal Sal. All right, so yeah, I'm Jeremy with EpiSoft, and Sally.
I'm Sally with EpiSoft.
There you go. And yeah, thank you all so much. Have a beautiful day, and we'll see you next time.
See you next time. Bye.